So good morning, everybody. I'm Amrita Kumar. I'm a consultant radiologist at Frimley Health, and I'm also the chair of the AI committee at the British Institute of Radiology. Andrea, thank you so much for inviting me today to share my experiences. I'm very aware that I know a lot of faces in the crowd, so I apologize if some of you have heard this before. But I thought Andrea's ask of me was, if now we're hearing AI, it's not like 4 years ago when we were trying to convince people of the uses of AI, everyone's on board. Policy change funding is being diverted to AI, as we can see on a national level. It's about how do NHS trusts set up. So the aim of this lecture will be for, if you are fresh, trying to set up AI, how do you coordinate it so as not to have the frustrations of knocking on individual doors and taking 9 months to get a DPIA signed off. So I have, I think, half an hour to go through a few topics. And I just wanted to start off with, why are we here talking about AI? Why is it not like any other medical technology? And then the implementation framework we used 4 years ago to set up at our NHS Trust on a trust-wide level before partaking on any AI work. And then the governance structures that we had to put in place, more importantly, because we're now moving towards using these things potentially in real time. So by no means is this a precedence, it's just that we're sharing our learning as to how we set up, and I'm more than happy to learn from other centers and tweak if needed. Why does AI differ from any other medical technology? Why can't I just, if a product is CE marked and has passed all its checks with MHRA, and is ready to procure, why can't I just go out, buy it, plug it into our system, and start using it? That's one of the main questions that everyone asks. It's frustrating for industry because they don't know why we can't just procure it and move ahead. It's frustrating for hospitals because they just like, if they know it's CE mark, why can't we just start moving it? There's quite a few reasons. The first and foremost is a lot of the research done to date in AI has really focused on the accuracy of systems. Now, with IRMA regulations in UK, we aren't actually in radiology imaging authorized to use AI technology autonomously without a human reader, a trained human reader in the pathway. So for any clinical assisted approaches, we need to still keep a radiologist in, which makes it very difficult to build a business case. Why would a trust spend money if they can't immediately add a productivity angle by replacing a radiologist? And anybody using AI vendors knows at this point, we cannot replace radiologists. We are using AI technologies to assist radiologists in expediting efficiencies or improving process outcomes. So the lack of evidence in real time to show true sort of return on investment, what are those benefit metrics that the trust could use to build a business case? And that's where a lot of research in the last 12 months has diverted towards, including AIDF that we're partaking in, because you have to look at the metrics that the trust will want improved, either speeding up cancer diagnosis, either improving the backlog, actually improving health outcomes for patients, or obviously in a win-win situation, making money for the trust. So these are some of the thought processes. The second thing is integration. As I said, we can't just go out, buy it, plug it into our CD-ROMs or somewhere else and just play the AI suppliers tech on our system. Actually, a whole integration piece is required that's quite exhaustive, because whether you're cloud-based or on-prem, it requires a bespoke integration element that involves the digital team, the PACS team, the IT infrastructure team, and the IT network team, something people don't realize. And with that comes other thought processes of funding and developing that in-trust domain expertise. Significant culture change is needed because there are multiple AI suppliers, and you need to engage with the clinical leaders so that you understand each process pathway from end to end. It's not just one part of the stroke pathway, it's the entire path. So that, for example, if we know that there are stroke products that expedite the identification of thromboses on CT heads that could expedite thrombectomies, you still need to speed up the ambulance coming to the hospital, the ambulance taking them on. All of these things need to be thought about from an end-to-end process. So it was just to give you a taster that it's not as simple as just buying the product. AI requires external facilitators, whether it's the right team, whether it's actually looking at the return on investment benefit metrics, or actually all the integration mechanics that go into setting it up. So I'd like to share, if you are a clinician interested in partaking in AI, how do you start to set up so that once you're set up, you don't have to keep replicating that setup for each project that you do. So I have laid out a 6-step implementation framework. A little bit of background how I started. My journey most already started in 2017 when we had 2 colleagues in breast screening leave on short notice, which left our reporting turnaround times for breast screening, which is usually 2 weeks, quite difficult to make up with the remainder consultants. At that point, we started thinking about upskilling, but that takes time. 5 years ago, we already had a lot of AI vendors that were already in the market in UK and USA, which we'd seen in the conferences. When we met with these vendors, we found that, well, there is a way of helping us make our turnaround times a little bit more resilient, other than consultant radiologists, but actually to even look at how it could improve that productivity, we'd have to have a formal trust-wide structure. When I came back to my R&D department and showed interest on, well, I want to set this up, whether it's a service evaluation because we can't use it in clinical practice, breast screening slightly different, we need the National Screening Committee's approval before we do anything. So even if we were to do a pilot study, how do we do it? At that point, my R&D department said, well, actually, the ophthalmologists are thinking of doing an AI in something else. The urologists are thinking about using it in something else. We should really have more of a trust-wide approach so that we don't have silos of research projects happening which require the same setup, the same stakeholders, but you're just not sharing any of the information or learning. So at that point, we took a step back and we thought, well, let's take a bird's eye view at trust level. How do we set up AI implementation? So we actually thought we're not going to rush ahead with a particular project just because I'm interested for my clinical pathway. We're going to set it up, delay any project, set it up at trust level so we get every stakeholder on board that can expedite all the different elements that I'm going to talk through. So actually the first thing we did was discovery and evaluation. Once we knew that there were a couple of projects different clinicians were interested in, because of the bespoke nature of integration for AI suppliers, we thought the way to engage it was actually at trust level to get an AI group together. And that required identification of the different people that are absolutely essential so that in one place, every yes is given as opposed to knocking on doors one at a time from IG to PACS to digital to whoever else needs to be involved. The easiest way to get the directors of all the different departments is to engage the chief exec and the medical director, because once the vision of what AI could do, whether it's research or service evaluation, once they aligned with the 5-year strategy of the trust and knew that it was important to the trust, and the chief exec and the medical director were on board, they themselves picked up the phone because they just wanted to know which were the stakeholders. And the stakeholders, most probably in order for me, were the first people were director of information governance, then procurement and contracts, then the digital team with the CIO, because for digital teams, it's no good saying digital teams, any project that has to be carried out by the digital team has to have an assigned PMO who brings together the network teams, the PACS teams, the architecture teams to see whether it's on-prem or cloud deployment. Because we have a good working relationship with our ICS, we had ICS people come on board as well. And then we had R&D and our clinical safety officer, because every trust has a CSO for digital health tech things. We kept HR involved because we didn't know if we needed to get in new talent just to grow the internal domain expertise. At this point, 5 years ago, nobody knew anything about AI, but once we got everybody together, project after project, the intention was to grow the internal domain expertise for us and the non-clinical staff. That's how we brought together the initial AI working group. At its complete core, and I've listed that there. Just to take it slightly a step further, we divided into key knowledge stakeholders, which I've mentioned. So because I was the radiologist and because we sold the vision, I became the chair of the working group, and we realized that for every project, we have a clinical lead. Now, for imaging, it was quite easy because I was a radiologist. I could take it forward. But for ophthalmology, all different specialties that required projects being looked at, we made sure we engaged with the clinicians, because without the clinicians, we couldn't get the sort of engagement for the end-to-end operationalization of any pathway with use for AI. Then, as I've mentioned, IG contracts, digital team, IT PACS. The decision experts were our R&D, because R&D already has a good governance structure for all research-directed projects. Now, we knew a lot of these projects weren't going to be research, but it would be good to learn from the backing and the framework that research and development already had in, so that we could make joint. We didn't have to replicate anything. It would be a joint pathway, whether it was a service evaluation or research, so that we didn't miss a step. We also engaged our trust board because having them be aware of why we were doing this, the resources, time commitments we were taking, and what we were hoping to give back was very important. They gave us access to the governors group because the patients sit on that group. And it was quite nice just seeing what patients at the trust wanted out of it. So just presenting to the governors group once a year meant we had engagement with our patient population that were driving a lot of the internal changes of the trust. Then for different projects, we could access patient groups, usually through charities and the PPI groups, depending on that clinical pathway that we were looking at. I've listed some of the external stakeholders only because we started quite some time ago when we first started out, there must have been 5 NHS trusts doing what we were doing. So we were a very small cohort. At the time, we had the NHS AI lab, which had most probably 3-4 people in it, as opposed to now there's hundreds. So it was a small world and all of us knew each other. So actually, since then, a lot of things have come along. We actually have the AI lab published procurement docs, actual NHS checklists for setting up. And it was quite nice because everyone talked to each other. We facilitated that conversation so nobody was replicating. People were learning off each other. There was no point reinventing the wheel each time. There was a real sense of sharing between the different stakeholders that were already playing out at national level. Then the nice evidence standard framework, for those not aware of it, please do have a look at it. It actually spells out step by step every value, every IT element, every return on investment, health economic side, how to begin looking at it. So anybody looking at it should really have already seen the evidence standard frameworks. The MAS, which is a multi-agency advisory service, is something that's come along the last year or two that has bespoke information, whether you're a tech company or whether you're somebody involved in actual implementation of AI. And HRA, we all have to be aware of, because if any of us are using CE marked products, we should be aware of what they are and how we can use them in the clinical pathway. CQC, I always say, because in the last few years, they've been more involved with AI side of things as we're deploying. But again, that's more from the hospital output side as opposed to the AI output side. There is a national AI strategy. We have innovation services. The National Screening Committee really applies to breast screening, and the HSNs were very good forms, especially because they undertook the most exhaustive piece of work as far as the stroke AI deployment was concerned, which started out of Oxford. So there are pockets of expert groups that you can share learnings with. I found in the last 5 years, most people are quite willing to share. No one's doing it in isolation, just so we can expedite who gets to it first. If they get to it first, they can share it with everybody else. We don't have to go through it in a painful way. The next thing was really to identify opportunities and value. And here there's a hybrid way of approaching it, and we did choose the hybrid way. One was, if you're a big academic center, actually you could build your own algorithms. That required a completely different skill set. It required more additional support from your R&D academic unit, from data scientists, from data analysts. Now, not every NHS trust has that at their disposal. I viewed it, because I'm in an NHS trust that does not have a big academic department or funding associated with data scientists and data analysts. We thought, well, that's one way to look at it. The other way is actually, there's lots of CE marked products. Well, let's think about using some evidence models to address bottlenecks like cancer diagnosis delays. We knew the way to start any of these projects was to make it worthwhile for the NHS trust. And NHS trusts all have targets, which if you discuss with your chief of service or actually the medical director, they can help you tune a business case as to what they want to look at, and if a project could potentially help with that, because funding is key here. And again, I was quite surprised that when people were interested in doing AI projects, they didn't really think about funding, because the IT department is not going to do anything for free. I think the only people who did anything for free for us was most probably the IG team and contracts. We didn't have to give them pockets of money. But digital teams, you cannot engage if you don't have funding. You have to have funding aside for digital teams. It's the only way I found they come to the table, and rightly so, because they have 1,000 digital projects going on. The way they prioritize yours is because you bring the appropriate funding, or it brings relevance to the trust to make sure that it gets prioritized ahead of others. And given that AI now is firmly in the top 3 areas where money is being made available, if you get the funding in, the digital teams do come straight to the table. So these two approaches are very personalized. So we actually, as a trust, I'll be honest, 5 years ago, we didn't have any expertise in AI. We knew we wanted to do it. We knew we wanted to learn in it. So the way we went about it is, let's partner with somebody who knows what they're doing, bring in funding, establish our internal infrastructure of what we think we need to be doing, and learn how other people do it, which meant let's do a research national collaboration. And to that end, we partnered with NCME, which is a National Consortium of Intelligent Medical Health, which was based out of University of Oxford. It was delivering multiple national level AI projects, bespoke projects, first of its kind, with 13 different NHS trusts that would come in as NHS partners so that funding could be diverted to them. And NHS trusts love it when you bring in funding, especially if they're not academic sites. It meant money was put aside for the clinicians, for the radiographers, for the digital team, for every team that required it, even our PACS teams. So people like that, look, we're going to put in more effort, but you are thinking about us. You're not just giving us more work to do on the same plate. And over that period, COVID struck. The good thing is some of those projects were COVID related for chest x-rays, which meant we could keep going. And as we took part in 3 portfolio studies. And in the course of those 2 years, we learned how they were actually managing all those projects. My IG team were turning around the DPIAs, learning how nationally it was being done by those centers. Digital team knew how to bring in AI companies on-prem deployment. So slowly, everybody in the trust was developing that domain expertise that was needed. And once COVID was over, we had done enough projects to know, well, now it's time to start deploying things that we are interested in, because now we know what we're roughly doing, having helped out at a national level. Then we moved on to, we got the Chiron Award for breast mammogram through the NHS England AI Award. And we also partook chest x-ray deployment, all in shadow mode, because we talk about research studies, which has its own governance and framework, which we partake alongside R&D. It's very important at this point to stipulate that service evaluations, because that's become the fanciful terms for everything else in AI, you have to be aware that currently, unless you have active monitoring, you cannot deploy in the clinical setting because you don't know how it'll affect the research setting, the actual patient facing. The second you touch the patient facing, it becomes a research project because the HRA questions around it change. So we made sure that we didn't. We had to learn now as we were moving towards clinical deployment of CE mark products. How do we set up the safety structures in our clinical pathway so that one day we can move to live deployment where we can actually affect the patient interface? So to that end, the projects that we did required integration at the clinical level, but it was to ensure that we could put the safety parameters, the governance structures, but not affect the live decision making because we didn't have authority to do that. And this is where I can talk about AI platforms because they will come in for integration and for the monitoring. Once a project was planned, we had to actually process map each project and then think about, well, funding has been brought in, what different stakeholders and users need to be brought in for each project, create the scorecard needed so that we knew exactly what benefit metrics we were looking at, whether we were going for a triage prioritization angle, an efficiency angle, a productivity angle, patient outcomes, or financial. We had to think as a business case, how I was going to build this case for this particular study so that there would be actually metrics that I could be governed on at the end of it. So we went through the stages of project plan, building a minimum viable machine, and then deploying and scale. Saying deploying, we weren't deploying in real time because we couldn't. We wouldn't be able to affect the real time, but we started deploying silent mode, running it in parallel to real time to see how the AI is comparing against the human outputs in the same clinical pathways for both of them. So what did we learn as we were setting up the projects? Well, it's great to set it up. We could actually process map each of our pathways, and we could outline how the AI was integrating and at which points we would use the AI, whether it was in chest x-ray triage or if it was in breast cancer screening, does it match up with normal identification with 2 other readers or with abnormal identification? But actually, as we were doing this, we were developing a bigger idea of, well, what safety structures and governance structures do I need to put in place if one day I go live? To that end, we sat down with our clinical excellence teams at the trust and said, we have to build a formative governance structure around this. And to that end, the objective of this was to have a dashboard for all our projects, whether they were R&D or service evaluations, so that we had a structured, organized, and transparent method for managing the life cycle of all AI studies from beginning to end. It wasn't based on somebody saying yay or nay, that I have done this, I have not done this. Everything was documented from the DTAC form to the IG to all the checks that were happening and monthly reporting structures. So the AI working group was how we started out, and that is there. But actually what developed was monthly meets with what we made into a AI governance group. And this governance group meets every month. The chair of the AI working group sits on it, the director of IG, who we tried to appoint the same person because we had to make sure that one person built their domain expertise first, and then you spread it. It wasn't my job to show the IG team what they needed, but they needed for all the different projects. But once they had their own internal expertise, they made sure everybody else around it came on board. So IG sat on it, digital team. It was invited for the CIO, but the CIO is very busy. They can't come to all the governance meet, but there has to be one point person. And we actually picked somebody from the digital architecture team. And our CSO was very important. Then we came up with a formal set of pathway so that no excited clinician could suddenly start a project without the trust, knowing that was happening and funding being thought about. And we made sure the way we would find out is because any projects that happen, if they went straight to IG without coming through the group, IG would bring it to that group because IG had to be on board and IG would make digital team on board, because there's nothing more frustrating for a digital team than having them have someone knock at their door saying, hey, here's a project everybody signed off on other than the digital team. So from the word go, everybody prioritized which projects would happen. And we actually know in the next 6 months what is coming down the pipeline, if any. And we work within the resource limitations of what we have, because there's only so many projects. And we're now about 6, 7 projects in, but at least 4, 5 of them have finished. So we knew at all times how many projects were ongoing at the trust and could plan for it. But we did come in with an exhaustive way, so we knew at which points to start, stop, go ahead, any other questions that were being asked. And we appointed an AI lead for the R&D department so they could liaise with us for all the formal research studies as well. The point of it was to capture the learnings, because sometimes the trust is doing some fantastic work, but you're not disseminating what's being learned even within the trust, let alone outside the trust. We created a dashboard so we knew every project that we were doing with metrics that were kept there. And then for each project, we came up with a project plan, which was detailed so that everybody in the committee knew what was happening alongside and who was responsible for it. Alongside that, we came up with a risk management system and a benefits realization document so that, again, from the beginning, we knew what we were thinking. These are evolving documents, but we kept adding to it. The point of it was that we had a structure to it. It wasn't at the mercy of an individual, and we were capturing everything that we were doing in as much as we could. And it's very much a learning process still for us, but at least there was a way that everybody was capturing the results. I've given you a whistle-top tour of how we have set up, so I'm happy to take any questions so I can go into any details that you have. So thank you very much for your time.